Pneumococcal disease usually presents with a sudden onset of high fever, shaking chills, and pleural pain. Cases with pneumonia have difficulty breathing and coughs with bloody or rusty sputum. Sinus and middle ear infections usually occur in children with other viral infections. In a small number of cases, the infection may spread to the bloodstream and then to the central nervous system, resulting in acute purulent meningitis, also known as pneumococcal meningitis. This may also occur without any prior clinical symptoms and may be fatal in a small percentage of cases, but this is significantly higher in seniors. Pneumococcal disease is transmitted from person to person by either direct contact or aerosols from coughing or sneezing. Since pneumococcal disease is mainly community-acquired, occupational and social risk factors include crowded living conditions in settings such as daycare centers, prisons, and army barracks. Alcoholism and drug addiction also increase the risk of infection due to decreased phagocytic activity and depressed cough reflex, which results in increased aspiration of foreign material. Pneumococcal disease is the leading cause of pneumonia and is endemic in North America. There is a high incidence in healthy carriers who are asymptomatic. Infections are most common in very young infants, younger than the age of 1, and elderly seniors over the age of 60. Other predisposing factors include existing infections of the respiratory tract and underlying chronic illness. In the past 10 years, the incidence rate of invasive pneumococcal disease in Canada has remained relatively stable at around 10 cases per 100,000, ranging from 9 to 11 cases per 100,000, which corresponds to 3 to 4,000 cases per year. The rate in Ontario, indicated by the purple line, were also fairly stable, hovering between 7 and 10 cases per 100,000, which was on average slightly more than 1,000 cases a year. This rate decreased sharply in 2020. The rates in Toronto were slightly lower than both the provincial and national rates, except for a few years. There are about a couple of hundred cases in Toronto each year, but this also decreased sharply in 2020, reflecting the provincial rate. The latest National Lab Surveillance Annual Summary in 2015 reports that the highest incidence rates of invasive pneumococcal disease are in infants younger than a year old at 14.5 cases per 100,000, in adults who are 60 years and older at 20.3 cases per 100,000. This is at a higher rate than the average of 9 cases per 100,000 for all age groups. A case of invasive pneumococcal disease is confirmed either when Streptococcus pneumoniae is isolated from a normal sterile site, or the presence of DNA is demonstrated with invasive disease, which manifests itself mainly as pneumonia with bacteremia, bacteremia without a known site of infection, and meningitis. Pneumonia without bacteremia is not notifiable. The clinical specimen required for laboratory diagnosis is sputum and smears from normally sterile sites. Gram stains or smears are used, and strep pneumoniae are gram-positive, bullet-shaped diplococci. You can see the pictures of the bacteria magnified with a scanning electron microscope on the far left, after an immunofluorescence assay in the middle, and a gram stain on the far right, with several neutrophils present. Strep pneumo is usually cultured on blood agar under anaerobic conditions in 5 to 15% carbon dioxide. Streptococcus pneumoniae is alpha hemolytic. In the picture, you can see that the bacterial colonies discolor the agar, turning it blackish green. As there are other gram-positive alpha hemolytic pathogens, more tests need to be carried out to confirm that the bacteria is actually strep pneumo. These are the optochin test and the bowel solubility test, which we'll look at next. Optochin is a quinine derivative that causes the selective lysis of pneumococci as other streptococci don't lyse. A zone of inhibition can be seen around the optogen disc after incubation on the right half of the plate where strep pneumo is growing. There is no lysis seen on the left side of the plate, which is covered in a lawn of other streptococci. Bile selectively lyses strep pneumo, whereas other alpha hemolytic streptococci are not lysed, and the culture stays cloudy. If you look closely at the tubes in the picture, it is only the fourth tube on the right that is clear, whereas the other tubes are cloudy. This tube is the one with strep pneumo. The first two tubes have another type of streptococcus in them, and there is no lysis in the saline negative control, or the tube with bile salts. The third tube is the negative control with strep pneumo and saline. Once again, there is no lysis observed, as bile salts need to be present for lysis to occur. The chest X-ray is used for the clinical diagnosis of pneumonia. The signs are opacity or white areas in the lung. In the picture, you can see a normal chest X-ray on the top, and both lungs are clear, whereas in the lower image, there is a white area on the lower part of the right lung, which indicates pneumonia. Initially, host predisposing factors are important in the infection to determine if it will cause disease. However, once bacteria in the lungs, in the alveoli, virulence factors include the polysaccharide capsule, which blocks phagocytosis. There are also two unique strep pneumo virulence factors, autolysin, which is a pneumococcal enzyme that degrades peptidoglycan and accelerates autolysis in bile salts, and pneumolysin, which is released when the bacteria lyses. Pneumolysin disrupts cilia on pulmonary cells and suppresses host inflammatory and immune functions. There are more than 90 serotypes of Streptococcus pneumoniae. Different serotypes have different types of surface capsules, which are made up of high molecular weight polysaccharides. Rapid serotyping of pneumococci can be performed by mixing the bacteria with a panel of specific anti-polysaccharide antibodies on microscope slides. Marked capsule swelling indicates that the serotype tested for is present. Pneumococcal infections can be treated with antibiotics. However, alternative antibiotics need to be used for a small percentage of penicillin-resistant strains. Vaccines are available and recommended for high-risk groups. The polyvalent capsular polysaccharide vaccine, which protects against 23 different serotypes of Streptococcus pneumoniae, is recommended for adults who are 65 years and older, whereas another type of vaccine is recommended for children. The vaccine for children is also a polyvalent capsular polysaccharide vaccine, but it is conjugated to the diphtheria toxoid and only protects against 13 serotypes of Streptococcus pneumoniae. It is administered in 4 doses to infants at 2, 4, 6, and 12 months of age. The main reason for the different types of vaccines is due to the low immune response in young children to the non-conjugated vaccine for adults. In summary, invasive pneumococcal disease is caused by Streptococcus pneumoniae. Invasive disease manifests as pneumonia with bacteremia and meningitis. The invasive form of pneumococcal disease is most commonly reported in the elderly and those with underlying medical conditions. 2 different vaccine types are available for children and adults. In this part of the lecture, we're going to look at the disease tuberculosis, commonly called TB for short. We're focusing mainly on the pulmonary form of TB today. Symptoms of pulmonary TB are usually a persistent dry cough, cough with bloody sputum as the disease progresses, fever and night sweats, and loss of appetite with weight loss. Aside from the lungs, TB may also affect any organ or tissue such as the bone and joints, central nervous system, lymphatic and genitourinary systems. It may also be disseminated throughout the body in a form called miliary TB. There are also cases of asymptomatic infections, which are known as latent TB. Infections that are not infectious because they cannot be transmitted to others but may develop into active TB infections if the host becomes immunosuppressed later on in life. Transmission is mainly through inhalation of TB bacilli in aerosols generated by active TB cases by spitting, coughing, or sneezing. The infectious dose is very small, and less than 10 tubercle bacilli may initiate an infection. Occupational and social risk factors are increased in enclosed, poorly ventilated, crowded environments such as submarines, crowded nursing homes, and homeless shelters. The incidence rate of TB was declining and was thought to be one of those diseases we had conquered. However, in the past decade, there have been high or at epidemic levels in developing countries, and many developed or industrialized countries have reported increasing incidence rates. 1/3 of the world's population is estimated to be infected with TB. Annually, there are around 10 million new active cases and 3 million deaths across the world. In developing countries, the TB epidemic is due to inadequate public health and TB control programs, including lack of laboratory diagnostic capacity, insecure TB drug supplies, inadequate treatment and follow-up of diagnosed cases. The situation is made worse by widespread poverty among disadvantaged populations and the HIV epidemic. In developed countries, the emergence of TB is attributed to a number of causes. Low or decreased funding for public health and TB control programs, as the disease was thought to be under control. Immigration from parts of the world with high prevalence of TB, the HIV epidemic, and the growth of disadvantaged populations, such as the inner-city homeless. Another major reason is the emergence of drug-resistant strains, which is primarily the result of inadequately completed or improper treatment regimes. In Canada, we continue to have one of the lowest reported incidence rates of TB in the world, despite the global epidemic. However, many of the same factors that have contributed to the changing TB situation in other developed countries also exist here. Although relatively uncommon among the general population, there are certain high-risk groups that have more incidence of TB. Indigenous peoples, foreign-born residents from countries with a high TB prevalence, disadvantaged inner-city populations, and HIV-infected individuals are all in these high-risk groups. This graph shows the relatively stable national Canadian rates over the past decade that were around 5 cases per 100,000 population, corresponding to between 1,500 to 2,000 cases a year. The rates in Ontario, indicated by the purple line, were also stable, just below 5 cases per 100,000, which is on average around 650 cases a year. The rates in Toronto were significantly higher than both the provincial and national rates, more than twice in some years. There were about 300 cases in Toronto each year, accounting for about half the cases in this province. Aside from Toronto, there is also a disproportionately high number of cases in Nunavut in the past 10 years, with an incidence rate of 266 cases per 100,000 population in 2017, which is more than 50 times higher than the national rate. The highest incidence rate was reported in the 75-plus age group at 10 cases per 100,000. There was also a gender bias with more cases reported for males than females. The Canadian rate of TB has been in decline for decades due to improvements in public health and living conditions, as well as the introduction of antibiotics. Looking at the case trends, in 2017, the majority of cases reported were foreign-born residents, and this is a disproportionate distribution because at the time, only 22% of the Canadian population were born abroad. Nearly a fifth of the cases were Indigenous Canadians who were born in Canada. This group only represented 5% of the Canadian population. So once again, there were more TB cases in this group than the rest of the Canadian population. The remainder of the cases, under 10%, were non-Indigenous Canadians who were born in Canada. It is therefore very important to note that in contrast to the first two groups, with 90% of the cases, the last group represented the majority of Canadian residents. A case of tuberculosis can be confirmed by laboratory diagnosis with a demonstration on culture from a specimen taken from the patient of Mycobacterium tuberculosis complex, that is, Mycobacterium tuberculosis, Mycobacterium bovis, excluding the BCG strain, or Mycobacterium africanum. Alternatively, clinical confirmation can also be made in the absence of cultures for cases that are clinically compatible with active tuberculosis. These are cases that have, for example, chest radiographic changes compatible with active tuberculosis, active non-respiratory tuberculosis in other parts of the body, pathologic or postmortem evidence of active tuberculosis, or favorable response to therapeutic trials of anti-tuberculosis drugs. One of the most common tests associated with TB is the skin test. Purified protein derivative, the main antigen from the tubercle bacilli, is injected intracutaneously, as can be seen in the picture on the left, then read 2 to 3 days later. A positive test will have indurated erythema, or raised hardened swelling at the site of the inoculation. A positive result does not imply active TB, but either previous exposure to the TB bacteria or past vaccination. The case then needs to be confirmed. This can be done clinically by chest X-rays for pulmonary TB. You can see hazy infiltrates in both lungs of the TB case in this picture. Tuberculosis is caused by a group of bacteria called the Mycobacterium tuberculosis complex, which includes 3 species of mycobacteria: Mycobacterium tuberculosis, Mycobacterium bovis, and Mycobacterium africanum. You can see a highly magnified scanning electron microscopy image of mycobacteria in the picture. Depending on the type of TB, clinical specimens that need to be submitted are sputum for pulmonary TB and other bodily fluids for other types of TB. Acid-fast staining is used instead of the gram stain. Can you remember why? Well, mycobacteria have very thick, lipid-rich cell walls, so they don't stain well with the gram stain. So acid-fast stains are used instead. TB bacilli can be seen as the long red-purple strands against a blue background in the picture. Fluorescent stains can also be used as an alternative, as they tend to be more sensitive. It's relatively easy to spot a fluorescent microbe against a dark background. Bacterial culture is required for lab confirmation. Mycobacteria can be grown in selective broth or solid media, but they grow very slowly, and colonies may not show up for 3 weeks or more. Due to this long waiting period, other most rapid tests, such as nucleic acid tests, are now used. The polymerase chain reaction, amplification, and subsequent probing of specific genes is very sensitive and also useful for identifying the different species of mycobacteria in the complex. As was mentioned in a previous slide, mycobacteria have lipid-rich cell walls with long-chain fatty acids called mycolic acids. This makes them difficult to stain, and heating is required, and also destain using acidified alcohol. They're also unusually resistant to drying, disinfectants, acid and alkalis. They disrupt phagolysosome fusion in macrophages and are highly resistant to oxidative killing. So they are able to grow in alveolar macrophages in the lungs, where they become surrounded by multinucleated giant cells made up of macrophages, lymphocytes, and fibroblasts, which form granulomas. You can see one in the picture with a lone acid-fast stained bacillus in the center. The macrophages die in the center of the granuloma, forming a necrotic lesion of dead cells. The lesions heal, but if located in a well-oxygenated tissue, for example in the lungs, mycobacteria may remain viable for long periods in latent TB infections. TB may reactivate. Lesions can spread and coalesce, forming large necrotic areas. Pulmonary cavities form. Weight loss or consumption, a term commonly used to describe TB, is a clinical symptom of advanced active TB. In the tuberculin skin test, there is inflammation resulting from delayed type hypersensitivity. This is due to a cell-mediated immune memory response and the intense infiltration of macrophages and T cells at the site of the inoculation. The treatment for TB involves special antibiotics that need to be taken over a long period of time, around 6 months. This is why there's so much resistance, as many cases are not able to complete their treatment, and the infection is not eliminated completely, leaving resistant mycobacteria in the host to infect others. If the first-line drugs are not effective, the TB strain is regarded as multi-drug resistant, and then the case needs to be treated with second-line drugs. If these are ineffective, the TB infection is referred to as extensively drug-resistant TB. There is a vaccine available to protect against TB. It is called BCG. In Canada, it is only used routinely in First Nations and Inuit communities with high rates of TB. Contact tracing is used in the prevention of TB transmission, and TB cases are interviewed to identify contacts. The contacts are screened, and if active TB is present, they are provided with appropriate treatment. Latent infections may be given prophylactic chemotherapy. Now let's look at a different group of bacteria. These are also streptococci, but they belong to a different species and cause very different diseases. This group of bacteria are called Group A streptococci, or GAS, G-A-S. Common diseases that they cause are strep throat or pharyngitis, sometimes with a characteristic rash known as scarlet fever, and impetigo, which is a skin disease that results in crusty red sores on many parts of the body, usually the face, but also on the limbs. These conditions are not reportable as they're usually non-life-threatening. Some of these Group A strep diseases may be followed by more serious sequelae. Acute rheumatic fever may occur in some cases about 3 weeks after a respiratory infection. There may be fever, malaise, and inflammation of the heart. Further recurrent infections lead to heart muscle and valve damage. Acute glomerulonephritis may occur in other cases. This usually follows a skin infection about 3 weeks later. There may be hypertension, blood and protein may be present in urine, and in rare cases, kidney failure may occur. In a small number of cases, severe systemic illness may develop, resulting in a serious condition called streptococcal toxic shock syndrome. This form of streptococcal disease usually starts as muscle aches and chills, with severe pain at the site of infection, which is usually the skin or soft tissue. If the extremities are involved, the infection can develop into flesh-eating disease or necrotizing fasciitis. It can continue rapidly with nausea, vomiting, and diarrhea, followed by hypotension, shock, and organ failure. Infected limbs may need to be amputated, and the disease may be fatal in approximately 30% of cases. While all the other streptococcal diseases are not reportable, invasive Group A streptococcal disease is a reportable disease. Group A strep is transmitted from person to person by direct contact with mucosal secretions from the nose or throat of infected persons, or infected skin lesions such as wounds or sores. Asymptomatic pharyngeal carriage occurs among all age groups and is most common in children. Individuals who are ill, such as those who have strep throat or skin infections, are most likely to spread the infection, whereas asymptomatic carriers are much less contagious. Treating an infected person with an antibiotic generally eliminates their ability to spread the bacteria, and it is important to complete the entire course of antibiotics as prescribed. There has been an increased incidence in North America of streptococcal toxic shock syndrome and necrotizing fasciitis since the 1980s. Only a very low percentage of all group A strep infections become invasive. Risk groups include the elderly, individuals who are immunosuppressed, or have underlying medical conditions such as cardiovascular or respiratory disease and diabetes. It may also occur in those with skin lesions, for example, children with chickenpox, persons with penetrating trauma or surgical wounds, and intravenous drug users. This graph shows the steady increase in national Canadian rates, ranging between 4 to 8.6 cases per 100,000 population, which corresponds to between 1,400 to 3,200 cases a year. The rates in Ontario, indicated by the purple line, have also increased from 3 to 8 cases per 100,000 population, with around 500 to more than 1,000 cases per year. The rates in Toronto follow the provincial national increasing trends from 3.9 to 6.1 cases per 100,000. This corresponds to an increase from less than 100 cases a decade ago to more than 200 cases in Toronto recently. The reason for the peak in 2014 was not identified. The criterion for a confirmed case of invasive group A streptococcal disease is the laboratory confirmation of infection with or without clinical evidence of invasive disease by the isolation of group A streptococcus, that's Streptococcus pyogenes, from normal sterile sites, which are listed on this slide. I won't read them all out, as we will see them again on the next slide. I just want to point out that at the end of the list, you'll notice that aspirates from superficial wounds, such as skin and soft tissue abscesses, are excluded, whereas deep tissue specimens and fluids from sterile sites are included. As was mentioned on the last slide, clinical specimens that are suitable for lab diagnosis include blood, cerebrospinal fluid, and fluids collected from normally sterile sites, such as pleural, peritoneal, pericardial, bone or joint, as well as deep tissue specimens. Group A strep, also known as Streptococcus pyogenes, is a gram-positive cocci, but since there are other bacteria and streptococci with similar morphology, culture on blood agar plates in anaerobic conditions with either 10% carbon dioxide or stabbing the inoculum into agar needs to be carried out to confirm its identity. The colonies should be beta hemolytic. There are a number of different groups of streptococci based on their carbohydrate cell wall antigens. These are the Lancefield groups from A to H and K to U. Group A strep are pyogenic pus-producing streptococci that are beta hemolytic. Beta hemolysis is when bacterial colonies are surrounded by clear zones of hemolysis on blood agar, as would be observed in strep pyogenes cultures, whereas alpha hemolysis is when there is a hazy green-black discolored agar around bacterial colonies, as would be seen with strep pneumo cultures. Strep pyogenes can be identified by Lancefield group typing using immunofluorescence staining or agglutination assays. Also, rapid bacitracin susceptibility tests can be performed as seen on the Petri dish with a bacitracin disc. You can see a zone of growth inhibition around the disc, indicating that the bacteria is sensitive to this antibiotic. As well, clear zones of beta hemolysis can be seen around the colonies. Streptococcus pyogenes has a number of virulence factors. The M proteins are hair-like projections from the cell wall, and there are more than 80 serotypes based on M protein antigenic differences. Their epitopes induce antibodies that cross-react with heart muscle tissue, playing an important role in the pathogenesis of rheumatic fever. Other virulence factors include streptolysin S, which is responsible for beta hemolysis, and streptolysin O, which is inactivated in the presence of oxygen. and requires anaerobic conditions. Strep pyogenes also produces pyrogenic exotoxins that can cause toxic shock syndrome. These are the superantigens that are able to stimulate T cells by non-specifically binding to MHC2 and T cell receptors. This activates large numbers of T cells, causing massive cytokine release of TNF, IL-1, and IL-6, resulting in endothelial damage, circulatory shock, multi-organ failure. These exotoxins are produced by M types 1 and 3. Group A strep infections can be treated with antibiotics. If streptococcal pharyngitis, that is strep throat, is treated within 10 days, rheumatic fever can be prevented, although this won't prevent acute glomerulonephritis. Antibiotics can be provided to prevent recurrent rheumatic fever during procedures that cause transient bacteremias, such as dental extractions. And this type of prophylaxis is usually recommended for individuals who have had rheumatic fever in the past. Good infection control is also essential to prevent the transmission of Group A strep, especially in long-term care homes.